Khalida, okay, to make it live and then
keep
give
it.
the link. Okay, it's live now. So give the link to the
Website link.
chat.
Yeah.
Yeah,
The
here.
link is creating. I will share within 2 seconds.
Mhm. Okay, can we, Dr. Bhupinder, are you there?
Yes, sir. She has
Ah,
joined.
yes,
Someone I'm
yes.
there.
Good,
Yes.
good,
How are
good
you? How
afternoon.
everyone? Good afternoon, everyone.
Good afternoon. Let me introduce her. She is the deputy WHO representative. Many of you knew Dr. Edwin Salvador. After Salvador's movement to DPRK, Dr. Bhupinder Aulak has joined as the deputy WHO representative. Welcome, welcome.
Welcome.
Thank you, Dr. Zaman, and hello, everyone. Good
Hello.
afternoon, and happy to meet all of you. Thank you.
Thanks for organizing this.
My pleasure.
So, Dr. Martin, if you give consent, then we can start.
Absolutely. Fine with me.
Okay, okay.
you.
So link is there on the chat. Anyone is interested to cast it live to Facebook, you can do it.
Okay, let me just.
Okay, how many of us has joined, Khalida? 54, right? 54. 54. Maybe some more people will join because interest was expressed by more than 85. I believe it was 87, plus the faculties. Should I start, sir? Vice, sir?
Oh, yes, please. Yes, please.
Okay,
We are
okay.
waiting. We are eagerly waiting.
With permission from Deputy WR, let me begin the meeting. So as you all know, the recovery trial is so far the largest trial in the world on COVID management. And it has already come up with a very important finding that has changed the guidelines, that has changed the evidences to the world of knowledge, to all those who practice, those who take care of the patients with COVID or COVID syndrome. So we would like to learn from one of the investigators of COVID recovery trial, Professor Martin Landre. He is the chief co-investigator of the trial, and he is a professor of Oxford University, and he will make the keynote presentation. I would like to also welcome Dr. Jahid Ikram, consultant geriatric medicine, Western Sussex Hospital, NHS Trust, UK. Dr. Tasbirul Islam, medical director, Division of Pulmonary and Critical Care, Indiana University of School of Medicine, USA. And with us, we have Professor Syed Atikul Haq, Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. We have Professor Muhammad Saidur Rahman. He's the Professor of Pharmacology, also from Bangabandhu Sheikh Mujib Medical University. And also we have with us Professor Mujibur Rahman. He has just been retired from Dhaka Medical College Hospital, but is still very active and taking care of the COVID research in Dhaka Medical College Hospital. And our very respected person, guardian of the current day's medical practice in Bangladesh, Professor M.A. Foiz. He was the former DG and he's a professor of medicine. We also see many senior persons from the government, Professor Mirzadi Sabrina Flora, Director IDCR, and also Professor Bajid Khorshid Riaz, he is the Director of NEPSAM. So I welcome everyone. This meeting will be moderated by Dr. Shakil Farid. He is the consultant cardiac surgeon of Oxford University Hospital, UK. He has shown keen interest to support the Bangladeshi doctors, to support the Bangladeshi patients and Bangladesh as a whole. So with these words, I would like to hand over the mic to Dr. Shakil Farid to moderate the meeting.
Thank you, Dr. Mustafa Zaman, for the nice introduction. It's my great pleasure to welcome my esteemed colleague, Professor Martin Landre, to present us the findings of the recovery trial. Professor Martin Landre basically graduated from Birmingham University, and then he did his clinical research in clinical pharmacology. He's a professor of medicine, epidemiology, and does a lot of cardiology clinics as well. So I had the opportunity of operating on many patients of Professor Landre. I can go on and on about Professor Landre if I have to, if I have the time, but for the interest of time, I would hand the mic to Professor Landre so that he can make his presentation. Professor Landre, over to you. Thanks.
Well, thank you very much, and it's a great pleasure to join you all. And if I can just share my screen. I'm hoping that you can now see my screen. Can I just check that?
Yeah, it's visible. Yeah.
Thank you. Okay, so the recovery trial, I'm presenting this really on actually hundreds and thousands of colleagues that make up the recovery trial investigators. And everything that I show is on the public website. The address is down there. So I want to take us back obviously in the UK, which is my initial perspective, to early March. And there, the pandemic was really just emerging. I first started thinking about this disease and the need for trials actually a couple of days before this was even declared a pandemic. We had heard about the stories from China, of course, and then from Italy, where the stories coming out of intensive care units in Italy were truly horrific, with intensive care doctors describing the decisions they were having to make as like a war zone, not having enough ventilators to put patients on, having to take patients off ventilators much earlier than they would want to do, having to make very difficult decisions, and with an enormous number of deaths. But of course, COVID or the viral infection for most people is just that, a self-limiting viral illness. The difficulty is that for hospitalized patients, then the mortality is in the order of 10 or 20%, or in some cases even higher. And for patients who are on ventilators, it's around 40 or 50%. So for the patients with the severest forms of disease, it really is a catastrophe. And so back in early March, we were thinking about how we would set up a clinical trial and the need for clinical trials. And what we recognized is that we needed to do this in advance of the main wave of the pandemic hitting the UK. This was not something that one could do later. It had to be there on day one so that doing the trial was part of clinical care. And that became, in fact, the National Health Service strategy, that the trial was part of clinical care. I mean, of course, the epidemics that we have seen in the UK and in Italy have been dwarfed by the pictures we've seen in the United States, for example. And when one looks at the global picture, the UK is just one piece of a much bigger global story. So this is an unprecedented clinical challenge, at least in the UK, an overstretched health service where we were worried about the availability of beds, staff and ventilators. There were huge time pressures and personal stress on frontline medical staff, and then very large numbers of unwell, anxious, often elderly patients who were alone. And the question was, how on earth does one do a clinical trial in those sorts of settings? Now, if we come to treatment, there were at the time no treatments proven to affect the disease. Many candidate drugs, actually hundreds of candidate drugs. There were many opinions about those drugs from many sources. Some were from people who set themselves up as clinical experts, some were from political leaders, some were from the media, and so on and so forth. But many opinions and no evidence. And there was frankly no reliable data. A few case series, often badly done, badly reported, a few small inconclusive randomized trials. And the World Health Organization, the European Medicines Agency, and many others said what is really needed now is a few large randomized trials rather than dozens or hundreds of small inconclusive studies. That would simply not take us forward. The question is, though, of those hundreds of drugs, how would one choose which ones to take forward? And this was our strategy. They needed to be some evidence that they might actually work. So that could be based on preclinical data, clinical data, perhaps in small studies, perhaps in similar viral disorders. We needed to understand the major safety issues. The drugs did not need to be perfectly safe, but we need to understand the profile. Really importantly, there had to be sufficient treatment available for large-scale recruitment in the trial, and then the potential to rapidly scale up if that treatment turned out to be effective. Having a proven treatment that nobody can either get hold of, administer, or afford is not a solution to a global pandemic. Now, the disease has really two phases. They're not separate, there's some overlap. But what one sees is that in the early on, there's a very heavy viral response. And the viral load is a key issue. That's over the course of the first week or so. Now, from a hospital perspective, those sorts of patients don't even reach the hospital. Or if they do, they're largely sent home because largely they're going to get better all on their own. But subsequently, for a few patients, they then become breathless, they develop acute respiratory distress syndrome, require intensive care unit ventilation, and then sadly die. And a lot of that latter phase is driven by the inflammatory response to the virus. And of course, your immune response initially is your friend, but later on turns out to be your enemy, driving much of the lung damage and potentially some of the other consequences too. Now, people have thought about how to target COVID-19. Worth remembering, of course, that back at the beginning of March, with a disease that's only 2 months old, there were at the time no specific treatments been developed for this disease, this virus. We simply hadn't had time. And that picture is evolving, and that picture will change over the course of the next 6 months or so, 3 to 6 months. But there are a number of drugs which will block the inflammatory pathway. There are drugs which will tackle various points of the viral pathway. And if one looks at what we're actually studying in recovery, and I'll come on to this in a moment, we in a sense are picking up 2 or 3 drugs in each side of that equation. So we studied hydroxychloroquine, we have studied lopinavir/ritonavir. You can see alongside lopinavir/ritonavir working on a slightly different pathway is remdesivir, of which we all know so much now. And then you can see the anti-inflammatory drugs, corticosteroids, azithromycin, and specific interleukin-6 antagonists. All those are, if you like, repurposed treatments. There are other areas one might want to look at, for example, anticoagulants, and perhaps various treatments that will deal with the renin-angiotensin system, but we haven't studied those yet, but they may well be what we study in the future. Now, what about the guidelines and the evidence base? Well, as I said, there really is no evidence base. So here is a review of the guidelines from May. Bear in mind, we're only in July now, in the various parts of the world. And I don't expect you to read them all, but I'll just highlight that on the left-hand side, the level of evidence for all of these things is essentially expert opinion. In other words, it's not really based on evidence. But what you'll see is that remdesivir, chloroquine, and lopinavir/ritonavir really appear as the sort of frontline agents in each of those guidelines on the left-hand side. So in particular, hydroxychloroquine and lopinavir/ritonavir very widely recommended as first or second line treatment. Which order depends on which guideline you want to read. On the right-hand side is the recommendations up until now, at least up until May, for corticosteroid therapy. And there's been a lot of confusion about corticosteroids in viral infections over the years, perhaps because they've been used in different doses, in different sorts of viruses, perhaps in mixed conditions, and at different times. And as we'll see in a moment, that leads to confusion. So many of those guidelines, in fact, all of those guidelines listed, essentially said either that steroids were not recommended or they were contraindicated. Some of them wisely said, except in the context of clinical trials. So these are the studies we chose, the drugs we chose to study. The antivirals, lopinavir/ritonavir, commonly used HIV treatment, hydroxychloroquine, of course, which has been around for decades, convalescent plasma, which we've only just started studying, and I'll just touch on briefly, and then immune system treatments, low-dose dexamethasone, azithromycin, and tocilizumab, a targeted anti-inflammatory focusing on interleukin-6, widely used in rheumatoid arthritis, but also in cytokine storm seen with CAR T therapy, which made it of some particular interest. And the design, we started with a very broad design. COVID is a condition that can affect anybody, and so the trial is open to everybody that's admitted to hospital. As I said earlier, if patients have mild symptoms, they're sent home. So anybody who's admitted to hospital with proven or suspected COVID was eligible for the study. It turns out that our youngest patient was, I think, 6 weeks old, and our oldest was something like 102. So it's a true full age range study. Here is the original sort of design. So these patients were randomized between, everybody got standard of care, but randomized between no additional treatment and one of those 4 additional drugs. Not all of those treatments started at the same time, so the numbers are not even, but basically patients could get one of those drugs or no additional treatment. And the outcome is 28-day mortality. It seemed to us that the real urgency was to find a drug in these very sick patients that would save lives. Drugs that reduce viral load or alter the inflammatory pathway or whatever else are all very interesting, but ultimately this is a condition with something between a 20% and a 50% mortality, depending on the types of patients you look at. Other outcomes are duration of hospitalization or the need for ventilation. Later on, in fact, over the last 6 weeks or so, we have added a second randomization. So in addition to one of those original drugs, patients can get convalescent plasma or control. But we have only just started that, and we're about 150 to 200 patients in that particular comparison. We also had one further randomization, which was for the very sick patients, the patients with hypoxia and with clear evidence of inflammation. So a much higher risk group, where you'd think they were towards the latter end of the spectrum, where the immune overdrive was really a key part of the issue. And they also were randomized then to tocilizumab versus control. So in terms of implementation, what you can see is this is the, if you like, the timeline for trials on the left that are global trials that we've been involved in. Initially with trials in China, run by my colleague Peter Horby, both sort of lopinavir and then of remdesivir, both were in a couple of hundred patients who was too small to provide conclusive results. On the right, what you can see is the UK outbreak, and you can see that the bars are the dark blue bars are the number of cases, and the light blue bars at the very bottom are the number of deaths. Essentially, we started this trial when there were only 20 or 30 deaths had occurred in total across the whole UK at that point. But we were really keen to make sure we got in at the beginning. We made the trial really simple because we understood that doctors and nurses involved in looking after patients with COVID were going to be busy enough as it was, without making things complicated by adding in a trial. So we had a very simple one-page randomization form, collecting minimal data, only the information we really needed, and simple centralized randomization. So what we were trying to do was make it almost as easy to randomize a patient into the trial as it would be to prescribe one of these drugs on the usual drug chart. We had a simple follow-up form, which was completed by the research nurses. Again, only about 6 or 7 questions. We are in the UK able to link through to national data sources, which is helpful, but not essential for this, covering things like information on death following discharge. And this is what the trial looks like. So we have 176 hospitals up and down the country. This is every acute hospital in the country is taking part. The size of the circle on the left represents the size, the number of patients randomized. So for where we are, if I can find the pointer. So this is Oxford down here with about 170 patients. This is Leicester with about 500 patients, and then a cluster of centres in London, but we've got centres right up in the north, right far in the south, and right across in Northern Ireland. And this is the profile of recruitment. And what you can see is that at one point we were recruiting over 400, nearly 500 patients a day at the height of the epidemic in the UK. It's tailed off a lot by now because this first phase of the epidemic has tailed off in the UK, thankfully. But we're still recruiting 20 or 30 patients a day, even in this current lull. This represents about 15% of all patients admitted with COVID in the UK. This is what recruitment looks like. We went from first draft protocol to first patient in 9 days. 8 weeks and 9 minutes later, we found that we were at 10,000 patients. Recruitment has slowed, as you can see, after that, for the reasons I've just discussed. The lower lines represent the number recruited to the tocilizumab comparison, and at the very bottom, the number of patients to the convalescent plasma. But you can see that those are just starting up. And as we continue the trial over the course of the next few months and into the autumn and winter here, we expect if there's a second wave of the epidemic, that the recruitment numbers will climb. So these are the results. So on average, there's about, on the first 10 or 11,000 patients, about 2/3 are men. The mean age is 66. On the whole, this is about a week since the symptom onset. These are very typical of the types of patients that are admitted in hospital in the UK over the last few months. Of the whole population, 25% required 25% required no oxygen or respiratory support. 60% required oxygen and with or without non-invasive ventilation, and about 13% required invasive ventilation. About a quarter each had diabetes, heart disease, or lung disease, so about 2/3 had some form of other disease at the same time. Again, typical of what's been happening in the UK. Here is the age range. You can see the extremes of age, but on the whole, most of the patients are between about 55 and about 85. So here is what we can see from the data. So this is obviously the overall information. In other words, I haven't shown you any information about treatment at this point. So on the left-hand side, a curve showing survival mortality over the first 28 days. Overall, about 25% of patients in the study died. You can see that that's very strongly related to age on the right. The mortality is higher in men than women. And of course, the mortality is higher in those people who require more ventilatory support, entirely as one would expect. So the first result was around hydroxychloroquine. Patients were randomized to hydroxychloroquine versus control as part of the study. It was a 2-to-1 design, so there's twice as many people in usual care as there's the hydroxychloroquine arm. You can see that the baseline characteristics are very much in line with what I've just shown you. And the study was stopped on the 5th of June, which was day 76 of this particular comparison. And the results announced later that day, when the Data Monitoring Committee had asked us to look at the data because there was no evidence that this was an effective treatment. So you can see that if anything, the hydroxychloroquine is slightly above the usual care line, in other words, a slightly worse outcome, but statistically, there's no difference between either of these two treatments. In patients who are in hospital with COVID, hydroxychloroquine is not effective in reducing mortality, and it's also not effective in reducing the need for ventilation or the duration of hospital stay. That's hydroxychloroquine. That result, as I say, was announced on the 5th of June and moved rapidly from results to implementation, so that 10 days later, the FDA, as an example, removed the emergency use authorization that they had previously applied. The second result that came out, it relates to dexamethasone. And again, a 2-to-1 comparison. This trial was actually stopped because we had reached the target sample size. We needed at least 2,000 patients versus 4,000 in usual care. That's what we had set the trial up to do. And when we reached that point, the results were then unblinded. And what you can see is that, again, the results are very typical of the types of patients who've been admitted. And among the sickest patients, those who required oxygen with or without non-invasive ventilation, or those who required invasive mechanical ventilation, there was clear evidence of benefit. So in the oxygen group, there was a reduction in the risk of death by about a fifth, from around about 25% to 20%. On the right-hand side, you can see that there was a reduction in the risk of death by about a third, and from around about 42% to about 28%. Now, people say, well, why have you picked out the subgroups? Well, the test for, the overall result is shown in the top left-hand corner of this slide. You can see there's a clearly significant result overall. But actually, when you look at each of these subgroups, either by eye or actually statistically, they are very different. So statistically, the chances of these three different subgroups, not on oxygen, or on ventilation, all being basically the same, is less than 1 in 1,000. These are three different groups of patients with different patterns of disease and response. So in those people who are not on oxygen, the dexamethasone was not effective, and in theory, at least, that's might have been that's compatible with some harm. But I think all one can conclude is it's not effective. In the oxygen group, I've just shown you the results. In the invasive ventilation group, even more impressive results. In the UK, dexamethasone costs about £5 for 10 days. In the US, it costs about $1 a day. And I think you would know the prices locally much better than I do, but as far as I can understand, it's less than $1 for the entire course. So recruitment stopped on the 8th of June. We announced the results on the 16th of June. This is day 89 of the study. We announced the results at lunchtime. By tea time, 4 hours later, the chief medical officers for the United Kingdom and the medical director for the NHS had issued a statement to every hospital saying, normally we would advise for the full paper before changing practice. However, given this clear mortality advantage with good significance and with a well-known medicine which is safe under these circumstances, we consider it is reasonable for practice to change in advance of the final paper, and that's what's happened. The WHO have made similar announcements, not I think formally in the guidelines yet, but certainly a very supportive statement. And then National Institutes for Health have included this now in their guidelines. So at the bottom, the COVID treatment guidelines panel recommends using dexamethasone in patients with COVID-19 who are mechanically ventilated and in patients who require supplemental oxygen, but who are not mechanically ventilated. The panel recommends against using dexamethasone in patients with COVID who do not require supplemental oxygen, which is exactly how I would summarize it. And then finally, lopinavir, ritonavir. This result only came out last Monday, if I've got my days right. Again, there had been a lot of interest in this, some information that it might actually be effective in animal models and in vitro. A small study, as I said earlier on, from China, where there had been 19 deaths versus 25 deaths. If that had been 19,000 deaths versus 25,000 deaths, it'd be a wonderful drug, but it turns out it's not. Really no evidence of benefit at all in that group. The one thing that's not on the slide, and I just sort of perhaps add, is that lopinavir, ritonavir is very difficult if patients can't swallow. It can't go down standard nasogastric tubes because of drug incompatibility with the tube, and the intravenous forms are quite difficult to get hold of. So we essentially haven't studied the drug in the people who are on ventilators, but I wouldn't hold out any great hope that it'd be effective in those patients. And again, this is impacted, picked up in the media, whether that's in the UK, in the US, or in Asia. And to support that, the WHO had their scientific congress this past week, and at the end of that congress, also announced that for their Solidarities trial, which had been studying originally hydroxychloroquine, lopinavir, ritonavir, as well as interferon and remdesivir, that the hydroxychloroquine and now the lopinavir, ritonavir arms would be closed. And the results which were shown at that meeting are very, very consistent with what I've just shown for hydroxychloroquine and lopinavir ritonavir. So this is not just a one trial phenomenon. We now have two large trials that have produced very similar answers for those two drugs. They're not effective treatments in this setting. So this is teamwork. Here's the team in Oxford, or at least this is about half of them. We managed to catch them when they're smiling, but it took us some time to get that photograph. Everything, as I say, that I've just said is we have all the information on how we set up the sites, the regulatory documentations, the protocols, and so on, and including all the results are all available online. It's been a huge teamwork in terms of many organizations. The top half of this is essentially funders, but the bottom half of this is organizations that have contributed. But most of all, this trial has been successful because of hundreds or thousands of doctors, nurses, and healthcare staff up and down the country, but also most importantly to the patients who have participated in an extraordinary project at the most challenging time of their lives. So I'll stop there. Thank you.
Thank you, Professor Londre, on a brilliant presentation. I congratulate you and your team on coming up with such a simple but robust study. And you gave results basically within 90 days, 100 days within the day of first recruitment. It's a brilliant study. We have some questions. I'm taking questions from the chat box. Whilst we are waiting for the questions from the chat box, I want to ask you a couple of things. You have shown that most of the patients who received steroids, they received it on day 8 to day 9, around that time. Can you think of any drug that can potentially help within the first week of illness? Because, in a country like Bangladesh, there is shortage of oxygen and hospital beds. So, it will be very useful worldwide if we can have some drugs which will halt the disease process or reduce the intensity of the disease.
Yes, I think I can answer two bits of that question. The first is we studied patients who are sick enough to come into hospital. And we didn't study patients before that. And I think in all parts of the world, the first week, patients largely manage at home. And then most patients just get better. It's a miserable first week of a very nasty viral infection, but they get better. But then some deteriorate, and that's when we get them. I think that there is a need for more trials in that first week. One would anticipate that that's when the antiviral treatments might have an effect. But frankly, we haven't found any decent antiviral treatments yet. The information on remdesivir is also largely in hospitalized patients, and in any case does not improve survival, and it's not a drug that's either available or affordable. So I think there's still more work to go there. The second thing I'd say is that the fact that these people needed oxygen is simply a marker of how bad the disease is. So if oxygen availability was limited, and actually even in the UK, there was a worry and oxygen availability was sometimes limited. So the criteria for when to give oxygen dropped from 94% to 92% because of rationing, essentially. I think when one has a patient who is hypoxia, and if you had an oxygen cylinder, you would use it, that's the point at which to give dexamethasone. If you don't happen to have the oxygen cylinder, that doesn't mean you should withhold the dexamethasone. But it's for those patients where the lungs are now clearly affected. That's the time to use it, but not earlier.
Thank you. That's very useful. Second question is the steroid dose adjustment. So if someone is already on steroid, how do you adjust the dose in the context of oxygen therapy and COVID?
Yeah, I mean, we essentially didn't. I mean, I think if you, it's a good question, but we left that to the local clinicians. And I suspect there will have been some patients who were on steroids who didn't get randomized because they were already on steroids. Perhaps for rheumatoid conditions or something, those patients wouldn't have been randomized, but I would continue their steroids rather than stop them.
Okay, thank you. Professor Atiq, do you have any comments about the steroid dose adjustment? Because I know a lot of your patients are on steroids. Professor Atiq is a professor of rheumatology. He's a chairman of one of the big university hospitals. Any comments, Professor Atiq? Atiq, sir?
Thank you very much. Thank you. You know, actually,
Hello? I think
lower than the, you know, lower than the dexamethasone 6 milligram equivalent. You know, dexamethasone 6 milligram is equivalent to approximately 45 milligram prednisolone. Most of our patients receive less than that. So in that case, you know, we can easily.
So sorry, Atiq sir, I think your internet connection is slow. We shall come back to you again. If you kindly disconnect and reconnect again. Whilst we are waiting, there are two questions on the chat box. One is from Nabil Fahmi Ali. The question is, as an MD in radiology oncology, I'm familiar with concept on adverse effects of tocilizumab. My question stands, is it safe to use this during a this drug in a TB endemic zone like Bangladesh? Also, does the drug have any proven clinical benefit in COVID cases? Any comments?
Yeah, so on tocilizumab specifically, I mean, I think the first is you're right. In a TB endemic zone, one might want to be quite a lot more careful around how it's used. Having said that, we're talking about essentially a single dose. Now, if one has I think there's a clinical decision to make. If one has a patient with who may have TB but actually has COVID and has let's say a 25, 30, 40% chance of dying within the next few weeks, I think there's a clear question about whether the risk that you might activate their TB versus benefit might change. Having said that, of course, at the moment we have no evidence for tocilizumab, no evidence at all. That will change, I think, quite significantly within the next 6 to 8 weeks is my guess. I don't know when the results for recovery will come out, but what I do know is that there are at least 2 other trials which are fully recruited. They're smaller trials, about 400 patients. The Covacta trial, which is run by Roche, and there's one whose name I've forgotten, but is in the United States, again, smaller. And they will produce results, I think, I'm guessing, in about a month or 6 weeks' time. So I think we'll know then. Because the first question is, does tocilizumab work at all? Because if it doesn't, you don't need to use it in a TB endemic zone or anywhere else.
Absolutely.
But I would say if it does work, then I think, like so many things, exactly the same is true with dexamethasone. People worry about the blood sugars and so on. Well, yeah, I mean, if someone's diabetes goes off a little bit for a few days, but you reduce their chance of dying by a third, I think most of us will reduce the chance of dying by a third. These are short courses of drugs in very, very sick patients. It's a slightly different equation.
Absolutely. Thank you very much. Tasbir Bhai, I know you are a great fan of tocilizumab. In States, it's used quite often, especially in the intensive care unit settings. Any comments? What's your experience about tocilizumab?
Thank you, Dr. Shakil, for it. Thank you, WHO, for inviting me. I was listening to Dr. Landre, and it was a very beautiful presentation. So tocilizumab, actually, we use quite often. If you look at the data initially, it was not good because it was used without steroid, because they thought the steroid may promote the replication of the virus, and that's why they're using steroid, tocilizumab without steroid, and the data was not initially good, but later it found it really helps. So actually, it's not a treatment for the COVID-19, it's a treatment for the cytokine release syndrome. That is, we need to understand. So those who have cytokine release syndrome, initially we use at level 3 and level 4, those who are already on vasopressors, on ventilator, critically ill, we use tocilizumab. But later we found actually we should start early, such as in level 2, like patient has soft blood pressure, recording fluid to get the blood pressure up, patient is tachycardic, all the inflammatory marker like CRP, LDH, ferritin is going up, we should use tocilizumab. But it is with steroid, not without steroid. So my experience with tocilizumab, good. And based on the observational study, it looks promising. We don't have the RCT study yet, but there is a certain few studies going on, like CONVACTA study, REMDACTA study, IMPACTA study, and MARIPOSA study. These 4 trials going on to look at the tocilizumab on COVID-19 with steroid. So I'm hoping, my experience, as you asked me, what is my experience with COVID-19? We use 1 dose tocilizumab 8 milligram per kilogram, max 800 milligrams in non-ICU patient. In ICU patient, if I don't see significant improvement clinically in 12 hours, we use 2nd dose, but not more than 2nd dose. I have one question to Dr. or Professor Landre. Why did you choose dexamethasone 6 milligram? If you look at the ARDS trial, if you look at the cytokine release syndrome, these are different dosing for different conditions, such as pneumonia, 1 dose, ARDS, another dose, cytokine release syndrome, another dose, but you use fixed dose, 6 milligram for all conditions. Just wondering, why did you choose that 6 milligram particular dose? Professor Landre, please.
Yeah, so the dose was chosen by my colleague, Professor Wei-Shin Lim, who leads the National Respiratory Guidelines Committee. My understanding is it was very much based on the idea that, particularly in earlier disease, I mean, this is still not early disease, that large doses of corticosteroid might dampen the immune response at a point at which there was still a high viral load. And so the question was around whether low dose would help. The other thing was that in some of the previous viral outbreaks, high dose methylprednisolone has been associated with a number of adverse effects, including avascular necrosis of the hip and so on. It's been interesting because it depends who you talk to as whether the dexamethasone 6 milligrams is low dose or high dose. If you talk to an intensivist, it's a low dose, and if you talk to a general physician or a primary care doctor, it's a high dose. I think that's just a perspective. But yeah, so we were keen to try and explore what a low dose would look like. It does, of course, raise the question, well, if we'd used more, would we have got a bigger result? And we don't know the answer to that. That may be something we can come back to, or others can come back to. I think the really interesting question is now, just to give you, the UK price is, if dexamethasone is £5 and tocilizumab is £500, then the question is, does tocilizumab produce an advantage above once you have given the dexamethasone? I think the answer is likely yes, but let's get the trials and know that. And I think that I do think we'll get those results relatively soon, or at least the starter for those results relatively soon.
Thank you.
Professor Landre, just to clarify, patients who are having tocilizumab, they are not getting any dexamethasone in the recovery.
Yeah, that was on top of whatever they were randomized to begin. So until 2 weeks ago, when we knew the results, then patients were randomized the first time to one of 5 treatments, one of which was nothing, one of which was dexamethasone, another was hydroxychloroquine, and so on. And then on top of that, they were randomized, those 700 patients were randomized to tocilizumab or not. Now, since we now know the results for the dexamethasone, everybody will be getting dexamethasone, and then they're getting tocilizumab on top of that. So we'll get information actually, both what happens when you don't have dexamethasone and when you do have dexamethasone, and that will be really useful, I think, because even trials like CONVACTA, they were sort of written in the old days when we didn't know steroids were, we didn't know anything about steroids, and I think this will be helpful to try and bring the picture on. But tocilizumab is the most expensive drug we're studying, and I think and only really suitable for particular, the severest forms of the disease, where the highest mortality is. That's great, but it's not where the big problem is. The big problem is the slightly earlier forms of diseases, and how one gets affordable treatments there, as you've said.
Thank you. Just going forward, the patients who are within the plasma arm, they are going to get steroid therapy as well, are they?
Yeah.
Dexamethasone?
Yes.
Okay, that's good. Thank you. Professor Atiq, sir, are you online? I don't think he's online.
He popped up once and then disappeared. Maybe we will have to call him back again. So Professor Saidur Rahman is here, Dr. Shakil Farid. Can we hear from
Professor Saidur
Rahman? He's a pharmacologist.
Yes, Professor Saidur Rahman. Can you please switch your video on?
Yep, it is on.
Mic on. Okay.
Oh, hi. Yeah.
Okay, hello. No, so thank you very much. Thank you
for coming over. So we have seen that a lot of medications are used in Bangladesh, like hydroxychloroquine, azithromycin, ivermectin, all of those things together. Can you tell us a little bit about this polypharmacy, you know, the adverse effects, especially to prolonging the QT interval and things like that?
Please. Thank you, Fred. Thanks, Professor Landre, for an excellent deliberation. Actually, I'm just enlightened, and it's a great privilege for me to be here. I said thanks to WHO Bangladesh, particularly Dr. Zaman, for allowing me and inviting me. As a matter of fact, I'm just an activist. I just act on, actually, as in the question you asked about, that is the indiscriminate use. What I talk about is in Bangladesh, what we are observing 3 pandemics side by side. Is the pandemic of COVID, and the infodemic, as all of us know, that there's a information pandemic, and the other one is in Bangladesh, that is the epidemic of indiscriminate use. And as you already mentioned, some of medicines which are actually not used in any part of the world, but these are used here, and some are common to other parts as well. As you mentioned, like hydroxychloroquine or azithromycin, these are common to some other parts as well, but not as such. Here it is, people are consuming, buying it, so they're keeping it in their home, and they're taking these medicines of their own. That is because of the health-seeking behavior here in Bangladesh and the availability of all medicines over the counter. So when they are scared, they're procuring it and keeping it at home and taking it, whether it is indicated or not, whether that is a COVID or not, that doesn't matter. They're feeling sick or getting scared, they're taking these medicines. And on top of that, then again, these are not that much used. Ivermectin, said already. Possibly this is only very few countries on good earth who are the people. These countries are consuming ivermectin as a remedy and prophylactically almost. And there are claims on the media, that is, people are claiming that that clear virus from nasopharyngeal swab 1/4 or 5th day, and all these claims on media encourage people to procure ivermectin and doxycycline. So people are getting 6 or 7 medicines at home. Hydroxychloroquine, azithromycin, ivermectin, doxycycline, and vitamin C, vitamin D, and zinc. All these 6 or 7 medicines people are consuming at home. So this is a very scary situation. So we cannot actually differentiate. You can ask about the QTC prolongation, all this stuff. This is impossible task here. It is almost millions of people are taking medicine of their own. Even if they're advised not to take this, they are not actually listening to that. In addition, they're actually right now they're taking oxygen cylinder to their home. That is the extent to which their indiscriminate use of all kinds of medicines are during this pandemic.
Yeah.
So it's a scary situation, and we cannot actually identify or we cannot explore the adverse reactions during this pandemic for any of the medicines because these are taken together.
Thank you, Professor Saidur Rahman. Atiq sir, can you hear me now?
Yeah, now I can hear. Yeah.
I think you have 2 questions to Professor Landre. Can you do you want to share your slides? I think you have a few slides here. If you kindly share screen, please.
Okay, can you share the slides there, because now I am disconnected. My laptop is disconnected, or I can.
If you ask your questions, that will be better, because I think it will be difficult to share from my.
Thank you, thank you very much. Firstly, I must thank the team of Landre and also Horby and the whole team for producing a very good quality of data in front of us. And I should say that, actually we were in a puzzle. We have been using glucocorticoids in various phases. For example, in patients in ICU, they were being used at random, but with a hesitant mind because there was no legitimacy. And the recovery trial has given legitimacy to our hesitant decisions. Now we are using glucocorticoids without the issue of legitimacy to this. That is one contribution of this great trial. And also for patients who are not in ICU but hypoxic. That hypoxia is corrected with either a nasal cannula or face mask or CPAP or these things. In those cases, there was actually no evidence that dexamethasone or glucocorticoid could help. And now, so some of our doctors were prescribing, some were not prescribing to that group of patients, hypoxic patients who are not intubated. Now that hesitation also has been removed. Though there is one adverse consequence that because of a less thorough reading, many of our doctors are prescribing dexamethasone to patients with mild disease also, and we have to address this issue among ourselves. But there are some issues that has not been addressed by the recovery trial or its preprint report. Maybe, subsequent reports, it will be clear. The first one is, should we prescribe dexamethasone to the patients with hypoxia during the first week? That was a question that was raised by Shakil also, whether in patients first week of COVID-19 with hypoxia, should we prescribe dexamethasone? That is one. Then number two is, in patients with hypotension and cytokine release syndrome, we have been using hydrocortisone and methylprednisolone on some weak rationalistic basis, but not dexamethasone. Should we switch our practice to dexamethasone in patients with cytokine release syndrome and in patients with hypotension? Number three, we have been using in patients with severe COVID-19, for example, with ARDS, severe ARDS, dexamethasone at even higher dose, for example, 5 milligrams 6 hourly, 10 milligram twice daily, sometimes 10 milligrams thrice daily, 4 times daily. Should, can we expect any benefit, any additional benefit from such higher doses compared to 6 milligram daily? And my fourth question is, before starting dexamethasone, is it important to exclude nasopharyngeal SARS-CoV-2, presence of virus in the nasopharynx, and bacterial co-infection? These are my questions. I shall be very happy if Professor Landre addresses these issues. Thank you very much.
Thank you,
Professor Atik.
That's perfect. So let me try and address those, and if I don't answer, please come back. So the first question was, if you have a patient who needs oxygen, is on oxygen, but they've only been 3 or 4 days unwell, the evidence we have is that the dexamethasone will work in those just as it would in people who present later. The key is that you've got to the point that the lungs are now affected and affected badly enough to require oxygen. That largely typically happens in the second week, but if it happened in the first week, I would still use it in the first week among those people who need oxygen. The second question, I think, was dexamethasone or hydrocortisone or a different steroid. And I think that's related to the third question, which is about higher doses. I mean, as so often, all that one can say is this drug in this dose with this regimen gets these results. And I can't tell you whether if you use a slightly different corticosteroid or a higher dose, whether you would do better or indeed worse. There are reasons for thinking of, you can make up reasons, scientifically we can make up reasons why a higher dose or a different type of steroid might or might not be beneficial or harmful. But the problem is that none of them was studied. So if this was a complicated drug, if this was an expensive drug, then we might want to delve into that in a bit more detail. But the reality is this is a simple drug and it's cheap and available. So in some ways, I think this is one of those areas where the easiest thing to do is do what the trial did, and you just use 6 milligrams of dexamethasone. Remember, the 6 milligrams of dexamethasone could be given orally or intravenously. It was given for up to 10 days, but if a patient was discharged before those 10 days, they had essentially got better, then we didn't continue it any longer. And the final thing I think was about diagnosis. Do you need to confirm the COVID diagnosis, and do you need to exclude the bacterial diagnosis? Well, we had the criteria essentially a strong clinical suspicion of COVID. So the right sort of presentation, that you couldn't, that with breathlessness, and that you couldn't exclude, and that there wasn't an obvious other cause like heart failure or an obvious bacterial pneumonia or whatever. But we didn't go down to very deep. There didn't have to be enormous detail on that. You just had to have a strong clinical suspicion, and we certainly didn't wait for COVID testing. Now, depending on what the situation is locally, but certainly in the UK, when we started out, for some hospitals, it was taking 24, 48 hours to get the nasopharyngeal results back. And in a sick patient, waiting 24 or 48 hours is waiting too long. And so actually we had many patients who we said, if at the time you think this person's got COVID, randomize him into the study. And I think that was right. It's of course a lot easier, that decision, when the only thing your health system is seeing is COVID. I mean, essentially the NHS shut down to almost everything else except for COVID. Almost everybody who presented with a respiratory infection and respiratory symptoms had COVID. So the pre-test probability was extraordinarily high. Now, if one goes through a place, is in a part of the world or in a time when actually there are a lot more other causes of respiratory symptoms, then that picture might change. But I think I'd still come down to, if you think this patient's got COVID, clinically, you can't find another condition, there's not an obvious other condition, then it's reasonable to give them dexamethasone. And if it turns out they got something else, well, you can always stop it. But I think that would be how I'd behave. You don't necessarily need the positive test. Just to sort of finish that story, what we found out was that actually, by the time people were discharged, the tests were back, and probably over 95% or something of those patients actually ended up having a confirmed diagnosis. It's just they didn't have it on the day when they first presented. Not all of them, at least, anyway, because of the delays in testing and so on. Yeah, I think clinical suspicion is enough. Clinical suspicion plus rule out anything other that's obvious.
Thank you, Professor Landre. I think you have given a very important message. Especially, it's important for a country like Bangladesh, where results can take up to 3-4 days to come. And as we know from our UK experience as well, many times a COVID patient don't get a positive result. So it's really important to treat the patients based on clinical suspicions. Now, I would ask Dr. Jahid Ikram, our esteemed colleague from Sussex, who has dealt with a lot of COVID patients. He has gone through the recovery trial, and he's the author of our evidence chapter of our book. Do you have any comments, Dr. Jahid Ikram, about the recovery trial and anything you want to ask?
Oh, thank you very much, Shakil, for asking me. Professor Landre, I'm a geriatrician. I had a question about the patients who were mechanically ventilated. So they're quite young patients. They're 59 was the average age. I think we have a culture here of not ventilating older patients. So over 70 and especially over 80, hardly anyone was ventilated. What's your take on that? Can we say that patients over 80 are also as likely to respond to steroids, or is there going to be different?
Well, I think it's tricky. Amongst the patients who were on ventilators, there wasn't clear evidence that the age mattered. The dexamethasone result, as far as one could tell, was pretty similar. But of course, as you've said, we had very few age over the 80, because the practice in the UK over the last few months probably generally, but certainly over the last few months, was not to put 80-year-olds onto ventilators. Now, I think that the question becomes then, you flip it round and say, well, if you have an 80-year-old who's not on a ventilator, who perhaps should be on a ventilator but isn't, what are you going to do? We don't have an answer to that. I think that's difficult. You would expect, on the basis that the lung disease is driving that dexamethasone would be helpful, but equally you would expect that if you don't give a ventilator to someone who needs a ventilator, they're not going to do well anyway. I mean, you will have been involved much more closely than me on the front line about those difficult decisions about who to ventilate and who not to ventilate. But you're right, the number of people who were on ventilators who were over 70 or 80 was tiny in the UK, and we didn't run out of ventilators by and large. So although we thought we were going to, we never actually ran out of ventilators. So I think that there is this issue about the very elderly, and we don't have a direct answer. I mean, my hunch would be if the lung disease is that bad that you need a ventilator, you'd expect the response in terms of the response to the dexamethasone to be similar to those who did get a ventilator. The problem is you'd also expect them to die fairly rapidly of other things, the lack of ventilation specifically.
Thank you, Professor Londre. Whilst we're on the subject, Jahid Bhai, I would like to address another issue. You know, in Oxford, we use NIV quite a lot. So a lot of patients were on CPAP and BiPAP. I know the American strategy is slightly different. I mean, Tazveer Bhai can confirm us. A high-flow nasal cannula has been used more frequently in States. Can you tell us a little bit about your experience, Andre, with regards to BiPAP and CPAP? My understanding is we had very good results with that in Oxford.
Yeah, I can't tell you so we didn't study, of course, you know, in this trial we didn't study the non-invasive ventilation as an intervention in its own right. We saw pretty similar results with the dexamethasone, regardless of the method of respiratory support. There is an ongoing trial called, slightly confusingly called Recovery RS, respiratory support. It's actually a different trial that's looking into this. But yes, I mean, everything that I've heard actually from investigators across the country has been that non-invasive ventilation has been extremely helpful in managing many of these cases.
Thank you.
Dr. Ikram might be more familiar even particularly with the older patients.
Yeah, thank you. Because we have seen three strategies for respiratory management. So if you look at the Birmingham practice, so their practice was early intubation, early going on ventilator. So their initial results were not great, but you know, after a few months, when the whole results came out, it's equivalent to the results of rest of the country, which is a survival of around slightly over 51%. Whereas in Oxford, as you know, the strategy was early CPAP and BiPAP, and then they would go on a ventilator if they didn't improve with that, which goes with the experience Dr. Jahid Ikram had. Tazveer Bhai is here. Perhaps he can enlighten us a little bit. I mean, he's a great fan of high-flow nasal cannula, and I think in States, they had good experience with high-flow nasal cannula, isn't it?
Yeah, thank you, Dr. Shakil, for it. You're right. So in Society of Critical Medicine actually suggest high-flow nasal cannula before non-invasive ventilation or CPAP. There is a risk of, you know, aerosol generation from NIV or CPAP. In US, we think that NIV or CPAP is more aerosol generating than high-flow nasal cannula, number one. Number two, we also feel that high-flow nasal cannula is more well tolerated by the patient than the CPAP or non-invasive ventilation. Number three is the high-flow nasal cannula is also generates some PIP on the top of just giving oxygen. So, and also wash out the dead space. So it helps the ventilation as well and lower down the CO2. So in summary, in our hospital, all across the nation in US, actually, we use high flow before non-invasive ventilation or CPAP.
Thank you. Dr. Jahid Ikram, any comments?
Yes, well, what happened in England is that NHS England and also NerveTag gave guidance. First of all, NHS England said that high flow nasal cannula is much more likely to cause infection in healthcare professionals than CPAP, and that's why. Yes, well, what happened in England is that NHS England.
Mustafa, I think you need to mute the mic. Yeah.
Sorry. Okay. So because of that, that was one thing that the warning from NHS England. So everyone started using NIV, and hardly anyone used high flow nasal cannula. The second one was also from NerveTag. There was an issue with oxygen supply, where Watford Hospital ran out of oxygen, and every hospital was asked to have an assessment done about how many high flow nasal cannulas or CPAP devices they could use. And a lot of hospitals, the outcome was that actually they couldn't use that many high flow nasal cannulas because the oxygen supply would drop throughout the hospital if they tried to do that. I think that sort of assessment is being done in Bangladesh as well. I think Chittagong Medical College had an assessment, and the engineers said that if you use 10 high flow nasal cannulas, then your entire system is going to collapse and everyone's going to run out of oxygen. These were the issues that we had. So because of that, CPAP was used not just sometimes as a bridge to invasive ventilation, sometimes as a ceiling of care, and sometimes just for patients who didn't necessarily need ventilation, but they weren't doing well with even with a non-rebreathe. They're desaturating below 90%. So essentially it was from between 1 and 5 days. And yes, they couldn't, the ones who were not that bad could take it off for a little while, have a non-rebreathe or a nasal cannula and eat, and then put it back on. But for some, they were, yes, essentially nil by mouth for 2 or 3 days or maybe 4 days. But that's been the UK experience. I can't give you data at this point. But I think that will be an issue with Bangladesh, where if they try to use a lot of high flow nasal cannulas, they will run out of oxygen. And every hospital has to have an engineer assess their oxygen system to see how many they can use. Yeah, that's my comment.
Thank you, Jahid bhai, for your comment. Can everyone please mute the mic? I think there's a lot of sound coming. Atik sir?
Yeah.
I think your mic is causing a lot of noise. If you kindly just mute it for a while. I have a few other questions to Professor Landre. This is a question from the director of IDCR. He's asking whether the use of concomitant other drugs might have affected the results of the recovery trial. Any comments?
Yeah, I mean, we studied a very broad range of people. As I said, it was 1 in 6 of the entire admitted population. So there will be a lot of different drugs used there. I mean, we didn't see any obvious interactions, but we didn't study them very carefully. I think that what I would say is that for the hydroxychloroquine specifically, we strongly advised against using the sort of other drugs that might prolong QT interval. And for the lopinavir, ritonavir, there's a long list of interacting drugs, which again we advised against using those. That actually made it quite difficult for some patients to be randomized to lopinavir. So lopinavir turned out to be quite a difficult treatment for many patients to actually prescribe. But even when we did, as I said, there's no result. So I can't give a precise answer, but I think on the dexamethasone, I think there's no sort of clear evidence of some sort of important interaction.
Thank you. And just to clarify, every hospitalized patient had anticoagulation.
Yes. Yeah. Yes. I mean, high dose or low dose. I think I saw a question somewhere about that. We are considering how to study that formally in a randomized trial come the second wave, which we're all expecting.
Yeah. And any difference you have seen in BAME patients or any sex predisposition?
No difference by gender. We haven't looked at the BAME issue directly because we're still getting some of the data in, but just to give you that where we have got the ethnicity data in, which is largely for England rather than the other nations, then it's somewhere between 15 and 17% is the total BAME proportion, which is about what it is in the sort of national picture. And if you look within that, recognizing that BAME is a range of different groups of people, then each proportion looks about the same as one would see in the national picture. But what I haven't done yet is to look at the treatment effect in Black and Asian and minority ethnic groups and see whether it's similar or different to among the white group, because we haven't got the complete data in yet. That will be coming, and we will do that. That's been pre-specified.
Thank you. I think it will be interesting to find out what happens in the BAME population. Professor Faiz, Professor Abul Faiz, can you please switch on your video? Any comments you wanted to ask a question to Professor Landre?
Thank you. Thank you. I cannot open the video because it is stopped by the host.
Okay.
No problem.
Yeah.
It is really a privilege to listen to Professor Landre to give an excellent presentation before it is available in the press. I think as we have got limited resources, we are in a position not to provide optimum care in many situations, like providing optimal care, including facilities for doing monitoring through intensive care. For that reason, in Bangladesh, our guideline was a bit relaxed in terms of utilization of the drugs, as you mentioned, the earlier drugs like hydroxychloroquine and other drugs, but we don't use hydroxychloroquine anymore. But in the community level, there are other drugs which have been consumed. In our situation, where lots of cases are difficult to be confirmed at the first place on day zero because of delayed report, and also the availability of facilities are not very much extensive. So in that situation, and also we have got a very different types of hospitals across the country. And injectable drug or oral drug, I think you mentioned both, either injectable or oral. So in our case, as I understand, optimum duration at least 1 week after or before that event, if there is necessity for oxygen, if I understand correctly. And you mentioned the 6 milligram dosage. In our country, we have got dexamethasone 5 milligram injection. So in that case, can we provide 5 milligram injection plus 1 milligram or tablet, either by Hals tube or oral? Or people are using 5 milligram to injection 10 milligram. That is one aspect. And previously, people were in favor of using methylprednisolone. Do you think that this? I know that our guidelines, the committee, they will once the paper is available, this is now available, so they will switch over from methylprednisolone to dexamethasone. What's your view whether to use methylprednisolone? I think you have mentioned that you studied with dexamethasone. So what's your view about this different concentration of dexamethasone availability in countries like ours? Thank you.
Well, yeah, so obviously the formal position is we studied 6 milligrams and this is what you get if you use 6 milligrams. But we have to be practical. And if in fact 5 milligrams is if a policy is 5 milligrams means that more patients who have the relevant condition will actually get it, then personally I would go for 5 milligrams. I think probably the difference of 5 milligrams versus 6 milligrams is very small compared with the difference of the relevant patients get it at all or they don't. Just to reiterate on the how long do people have to have symptoms, it really does, in many ways, it doesn't really matter how long people have symptoms. What matters is whether they have hypoxia and would need oxygen. It doesn't even matter if they actually get oxygen, as I said earlier. If there's no oxygen available, at the point that you would want to give oxygen, you should give dexamethasone. If it's 5 milligrams and not 6 milligrams, then that's just fine. I think very often clear and simple and easy, and practical messages are a lot easier than trying to be too clever about it. I think 5 milligrams used widely would be, in those people who are hypoxic, that 5 milligrams used widely would be just fine. 6 milligrams is what we studied, it doesn't matter.
Thank you. I think your message is very loud and clear. It's low dose dexamethasone. That's the message, around 6 milligrams, whatever is available in the country. There are a few other questions. Professor Ziaul Islam has asked, did you find any synergistic effect with angiotensin receptor blocking agents?
We haven't looked yet, but we hopefully will be able to.
The other question from Dr. Nabil Fahmy is, can we explore respiratory specific steroids like fluticasone and salmeterol instead of dexamethasone?
Yes, but it would require a new trial. I don't think one can jump from dexamethasone to salmeterol or similar.
Absolutely, yeah. Thank you, Professor Mujibur Rahman. Can you please switch on your mic? So Professor Mujibur Rahman was the former head of Dhaka Medical College, which is one of the largest teaching hospitals in the country. He's the head of the Department of Medicine. He's also the controller of examiners of Bangladesh College of Physicians and Surgeons. He has been dealing with a lot of COVID patients over the last few months. So it will be great to know his insight and whether he has any queries. Professor Mujibur Rahman, over to you.
Thank you. Thank you, Shakil, for your nice conduction of this program. I must congratulate to Professor Martin Landry. They have been working very well and produced some sorts of evidence. During this pandemic, we are just in the dilemma, which one is effective, which one not, and they have solved to some extent the dilemma, which drug should be given to which patient. Thank you very much. Thank you for your very nice deliberation. In our hospital, what we used to do is the de-prescription of all the patients. As Professor Saidur Rahman has been told that our patients are using so many drugs in the community. When the patients come to the hospital, they have been taking so many 5-8 drugs before reaching to the hospital. So we need to de-prescribe all these medications, and we just prioritize which medicine should we prescribe. But the main thing is that we just prioritize giving oxygen, and after that steroid nowadays, and also some other medications like the thromboprophylaxis, as you have told, all of you know. But regarding the steroid, one question, I think it has been told that the study was done with dexamethasone, so it is dexamethasone. But whether the effect of this corticosteroid is a generic, the class effect, or is the effect specific to the agent, it's very tough to answer because it needs another study to say whether the prednisolone is working, whether the methylprednisolone is working. But to understand the things, steroids are working in a very common pathway. All the drugs are working in a very common pathway. So my understanding is that if we do use the equivalent other corticosteroids, what do you think about this, Professor Landry?
Yeah, I mean, I think the question is also what's their level of specificity, which obviously varies too. So it's not just dose; it's also specificity, which is, I mean, I'm not a steroid expert, as you've heard. I'm a cardiovascular doctor, yes, I think the specificity is an issue. The other thing, which I think, my clinical pharmacology background reminds me, and I've been interested in from what Professor Rahman was saying earlier on about the polypharmacy. I liked hearing it described as another pandemic. And so actually one of the most important things one can do when patients come to hospital is stop a load of medications they don't need. And so in some ways, in a sort of, it's not the way you'd expect it, but knowing that hydroxychloroquine doesn't work by the time you get in the hospital, knowing that lopinavir doesn't work, gives you confidence in stopping those treatments. There aren't actually any good reasons to believe any of the other antivirals particularly effective either. I have to say that vitamin C and zinc have never been shown really to be useful for anything except for when people really have deficiency, but I worry about them less than I do some of the other things. But I think that dexamethasone is specific in a way that some of the other steroids are not, and there's a dose issue. And then, as I say, I think stopping a load of drugs that patients don't need is actually good medicine. It's good for their health, and it's probably good for their finances and the health system's finances too.
Thank you, Professor Landre. There was a question from Nabil Fahmi, Dr. Nabil Fahmi. Is ivermectin competitive inhibition of nucleic acid by viral RNA a good option? Any comments about that?
Well, I think that, it certainly inhibits SARS-CoV-2 in vitro, but whether you can really get the levels up high enough to be an effective antiviral in patients, I think is a big question. And there's information, I think it was from influenza, that it sort of auto-induces its own metabolism. So the sicker the patient, and the more you put the dose up, the less you get, if you see what I mean. And so actually, whether, although it looks nice in the laboratory in the Petri dish, whether it actually does any good in the patient, I think there's a big gap there. And of course, it got a so I think that's the big gap on that one. The other one that's had a lot of press, of course, is ivermectin, and again, some in vitro activity. Again, the issue is about could you get the levels up high enough? And of course, it got a big sort of surge in use on the basis of an analysis by the now notorious Surgisphere, the people who retracted their paper in the Lancet and caused so many issues and concerns there. So I think it's not on the strongest evidence base, and I think these are all part of the questions that really one needs to be thinking about. If these really have a good role, then let's put them in trials and find out quickly. And it's not as if worldwide there's a shortage of cases of this disease. It really should be possible to get answers very rapidly. WHO are doing a great job through Solidarity. We've done our bit, or are doing our bit. I think it's noticeable, for example, in the US, that actually there's very, very few trials where you would expect them to actually be able to really tackle these questions. And so when I give other talks on other Sunday mornings with US colleagues, I do try to get them to think seriously about focus on what's simple and what matters and get the trials done. And sadly, they haven't. I think that's been very remiss.
Thank you. Any comments about hydroxychloroquine on chemoprophylaxis?
Yeah, we don't know is the short answer. There have been various observational analyses. Observational analyses are frankly hopeless. The patients who get a drug are so different from the patients who do get a drug. We as doctors make decisions about who we do and don't give treatments to, not all of which we write down, and not even if we did write them down, would they be sort of obvious. Patients take views about which drugs they do or don't get. There's all sorts of stuff going on. Patients who get a drug are just different to the patients who don't. So I think the observational data are just really, really unhelpful. They give you a level of confidence that is undeserved. And I'm working with a former FDA commissioner on exactly that issue. I think in terms of prophylaxis, that needs a trial, and the COP-COV trial, which is being run out of the center in Thailand, but does also include or is planned to include a large number of European healthcare workers too. We need the results of those sorts of trials. There is a similar one called Hero 2, I think it's called Hero 2, but in the United States, which is just getting going. So that's one trial they are doing. But you know, we studied patients who'd got to hospital and had severe COVID, and it's completely useless in that setting. We did not study patients with earlier disease, and we certainly didn't study prophylaxis. If you said, what do I, you know, this is the speculation now. I don't hold out great hope, but I think we need to know.
Thank you. Not a very scientific question, but what's your gut feeling about plasma therapy? Do you think it's going to work?
Well, I think actually we can. I think one can give a scientific answer. Actually, I think that if one gives convalescent plasma, but without selecting those with high levels of antibodies, I think that either will not work or might even cause antibody-mediated enhancement. I think there's a reasonable grounds for expecting that that plasma that does contain high levels might work. Having said that, just in the last couple of days, there was a small study out of the Netherlands which suggested that actually, when they looked at the level of antibodies in the plasma they were giving, and they compared them to the patients they were giving them to, that actually by the time patients were sick enough and in hospital to need convalescent plasma, many of them had antibody levels of their own, which were similar or at least as high as the ones in the plasma they were being given. Now, that was a very small study. It then led for their trial to be stopped, but their trial, in my view, was just so small that the fact they stopped the trial is, I think, neither here nor there. I think the interesting bit of that finding is that it appears that there are some patients who actually mounted quite a good antibody response and are deteriorating, and therefore in that group it might not work. And if we go back to the cartoon of viral load early on, cytokine storm later on, I can see that if you were to give a load of antibodies to people where the only issue really is the cytokine storm, you've missed the boat, and we're probably doing the wrong thing at the wrong time. But we're studying it. I think it's really important to study it. Again, back to the US, they've given convalescent plasma to 20,000 people. Unfortunately, they didn't randomize them, so they have no idea whether the patients they gave the convalescent plasma to did better or worse than the people they didn't give convalescent plasma to. So again, I think it's a serious mistake. Actually, we need the trials because there are open questions. But my speculation would be, I think that in the right group of patients, I think, and using good quality convalescent plasma with decent antibody levels, it could turn out to be really important. But we need to know. It's not a drug that's easy to manufacture. You've got to do a whole load of harvesting, and that's going to be a challenge for all parts of the world in itself.
Thank you, Dr. Tasbirul Islam. Can you tell in clear terms the indications for use of plasma therapy in patients? Because I know you are using that quite a lot, just in a simplified form.
What's that?
Just in a simplified form for Bangladesh, what should be the way plasma therapy should be used?
Okay, so I want to go back a little bit, if you give me a couple of minutes. If you look back about the serum therapy, it's really over 100 years old. It's used against diphtheria in 1891, and the first Nobel Prize was given to Dr. Bering, who actually works on the serum therapy, and it was used extensively until mid-30s when he got the antibiotics, and for polio until mid-50s. And the way it works actually is like a vaccine. The vaccine actually gives vaccine to ask the host to produce antibody. Here you give preformed antibodies to fight against the virus. So what is the data we have? I think we don't have a robust data. All the study we're talking about is all observational study. If you look at the data from Johns Hopkins, Mayo Clinic, or Mount Sinai, then Houston Methodist Hospital, they're showing benefit. And the US used a lot of convalescent plasma, as Dr. Landry said, but only one randomized controlled trial came out from China and published in JAMA. It was actually stopped early because they could not recruit 200 patients. They recruited only 103 patients, and they used only for severe and critically ill patients. And they showed no benefit at that time on that cases. FDA approved this convalescent plasma in late March, and we use since then. So important part is the donor selection. So we all know 20% does not mount any antibody. Those were recovered from the COVID-19. Over 50% do mount very low titer of antibody, neutralizing antibody. Only less than 30% actually mount high titer neutralizing antibody. So we have to identify those super donor, number one. Number two is that the titer, the FDA put the number is at least 1 to 160 to call it effective for treating the COVID-19 with convalescent plasma. But another thing you need to bear in mind, there's a cross-reactivity, because we are getting the antibody from the patient. We don't know it's real from the COVID-19 or is there a cross-reactivity with the other coronavirus, all the influenza vaccine recipient. We all know in US, 45% of the US population receive flu vaccine. They also can produce similar kind of antibody. And so there is a cross-reactivity that may not be effective to treat the COVID-19 patient. So important question is when to use it. Do you use it in moderate cases? Do you use it in severe cases? Or do you use it in critically ill patient? If you look at the FDA indication, they say it only used for the severely ill or critically ill patient. But the question is, we all know in COVID-19, there's two phases, viral phase and the immune phase. So it should work. Convalescent plasma should work in viral phase, not in immune phase or cytokine release syndrome phase. So we need to identify. So if you look at the convalescent plasma in treating pneumonia in the past, we used very early. Late use does not work in pneumonia. So COVID-19 is kind of pneumonia, it's a viral pneumonia. So hypothetically, it seems like it should work early rather than late. So the question comes in, they found those who are critically ill in the hospital, and they have a lot of high titer neutralizing antibody, but still they are doing poorly. That is the study came out, is they have already have a neutralizing antibody on their own, but still they're doing poorly. Why it is happening then? And then those patients, if you give extra antibody, probably it makes the things worse. There's a term called antibody-dependent enhancement of the infection, and that can happen there. So it's very important to know that it may actually, if the patient has antibody-dependent enhancement, it causes more viral replication. Number two, it actually augments the hyperinflammation causing cytokine release syndrome. So that's an important thing to find out the right person or right patient who will benefit from the convalescent plasma. So if you look at the paper from Wolf and his groups, what they found is they found actually you should give, if you think of giving convalescent plasma, you should give in viral phase, not in immune phase. That means within 8 days of the onset of symptoms rather than late after 8 days of symptoms. Just like remdesivir is antiviral, convalescent plasma is like antiviral. So it should be used earlier than late. So now the question comes is when to use it then? I think you should use in moderate case. Don't wait for the late critically ill or severely ill patient. You should use within 8 days of onset of symptoms. Number three, those who have, just like the indication for dexamethasone, somebody has pneumonia and going into bilateral infiltrate and going into oxygen requirements, those patients I think will benefit, but I won't wait until patient become critically ill or going to the ICU, go on ventilator, then use the convalescent plasma. In terms of dose, there's a 2 dose you can use. One dose is one dose, but you can use up to second dose. If you use the second dose of convalescent plasma in Mayo Clinic, they use within 12 hours of the first dose. Yes.
That's right. Just to clarify, so you are saying that as soon as the patient needs oxygen, you should use the plasma therapy.
In our hospital in Indiana University, we use actually convalescent plasma in the flow, that means who is in the ward. Those who have bilateral infiltrate and oxygen dependent, started oxygen. So even not critically ill. So yeah, you're right. Bilateral infiltrate on oxygen, we are using any level, 1 liter, 2 liters, we start using the convalescent plasma.
Thank you. Professor Landre, your comments about that, which patients are being included in the plasma arm of the trial, in recovery trial?
We're including all the hospitalized patients. It's too early to say. We don't have the numbers to know how the doctors on the ground are actually seeing this. We'll know that as we recruit more patients. And I don't know what the results will look like, but my feeling is we'll get exactly to where Professor Islam has just said, which is that it's much more likely to work in the patients who are earlier in the course than later in the course, amongst those who are in hospital. I think, you know, it's not a scalable solution for outpatients in primary care. And the other thing to always remember is that blood products have a nasty history of having hidden complications. That carrying diseases we know nothing about for 20 years. So, you know, I think one has to take this in a group of patients where you are happy to accept those risks. But my hunch is that it's going to be in the early hypoxic patients. But let's do the trials and find out, because it's such an important question. And I do find it really disappointing that the US have given tens of thousands of doses, or possibly more, and have no idea whether they're doing any good or not, or in whom they're doing any good. That's not good medicine.
Thank you. So the message is very clear from the two of you. One is early stage when they're going on oxygen or hospitalized. Second thing is you have to know the antibody titer, because we have seen in some places in Bangladesh, the titer hasn't been checked and it has been given multiple times to patients, like 3-4 doses of plasma, which can have adverse effects. There is an interesting question from Dr. Shakil. This is another Dr. Shakil. He happens to be from medical school, senior brother. He's a thoracic surgeon. Obviously, he will be dealing with lots of aftermaths of COVID-19. What about the long-term effects of COVID? Are you going to see a lot of extensive lung fibrosis? Any measures you can think of that will prevent that from happening? Would you consider increasing the dose of steroid, like lengthening the dose of steroid to reduce lung fibrosis or anything like that, Professor Landre?
We just don't know. I mean, we don't know about the fibrosis yet, and we don't know how to tackle it. I mean, there's only so much one can get out of a trial. We will study long-term effects of the dexamethasone because we're linked through to the health system records. We will try to, where we can, to also follow up with radiology. So maybe over time we'll know, but at the moment I just don't know. The first question really was, you don't get long-term consequences of a disease that you don't survive. So the first question is to try and deal with the survival issue. But yeah, it's an important question. What are the long-term consequences? We'll get some information, maybe not perfect.
Thank you.
Can I add something, Shakil?
Yes, sure.
I just want to know, steroid is the anti-inflammatory medications. It's not an anti-fibrotic medication. So when the patient going to the fibrotic phase, theoretically, it's look like the steroid doesn't work. If you look at the data for the idiopathic pulmonary fibrosis and look at the PANTHER trial in 2012, they used combination of steroid, azathioprine, and N-acetylcysteine actually do harm rather than do any benefit. So we actually come away from the steroid in idiopathic pulmonary fibrosis. So the question comes whether antifibrotic medication, that parfenitione and nintedanib, work for those patients. There's some study going on there. There's a paper came out in Lancet. It may help the antifibrotic medication, but surely I agree with Dr. Landre, Professor Landre, that I don't think so steroid long-term use is any benefit for post-COVID fibrosis. Dr. Shakil Farid.
Thank you. Thank you. Professor Landre, there's another question. Is there any future role for IV immunoglobulin in the fight?
Yeah, I mean, these are good questions. I might remind us all that this is a very common disease affecting some of the poorest parts of the world. So we're spending some of this discussion just now talking about some therapies which are not necessarily cheap or particularly scalable. So that's just a bit of context. We are particularly interested in IVIG and may even start testing it in the context of the unusual syndrome that the children get, where essentially the respiratory component is almost absent, and you have a very heavy sort of inflammatory component. So there's an interest in IVIG, particularly in that group. We're just considering whether to actually go on and study that. Beyond that, in adults, I don't have a particular view.
Thank you very much. I think we had very good discussions for almost 2 hours. We need to wrap up the session soon. It's Sunday here. Professor Landre kindly gave us his valuable time. Anyone, any comments? I think I will hand over to you, Dr. Mustafa Zaman. Thanks, Professor Landre, for this fantastic presentation and answering all of our questions. We look forward to seeing you in future in our sessions. I'm sure that this will be one of many sessions of future. Thank you so much once again.
Thank you for having me.
Thank you very much, Dr. Shakil. Before I request Deputy WR Dr. Aulak to make comments, I would like to have remarks from Director IEDCR. She will be the PI for Solidarity Study, and she is also running the Unity Study, and she is the focal point for COVID research in Bangladesh, assigned by the Ministry of Health. Can we hear your comments, Professor Sabrina Flora?
She muted. Professor Flora?
She was here. I was. Professor Flora, are you on the line? Okay, probably she left. Now I would like to request Dr. Bhupinder Aulak, Deputy WHO representative, for closing remarks, please.
Yeah, thank you, Dr. Zaman, and thank you, Professor Landre. This was an excellent and brilliant presentation. And the kind of evidence that this recovery trial has generated, I think this evidence is very important. And we talk about evidence-based medicine. So this is a time when we are confronting a corona pandemic. This evidence, I think, will be very useful and will inform the national guidelines of Bangladesh. So thank you so much. And I also like to thank Dr. Shakil for excellent moderation, for moderating all the questions and participants. And all the panelists who are there, I would not name everyone, Dr. Tasbirul and Dr. Ikram and everyone. So on behalf of WHO, I think it's my pleasure that we will keep hosting these kind of sessions so that we can generate as much as evidence as possible so that our fight against pandemic becomes more evidence-based and it can inform our future, preventive and also treatment arms. So thank you all of you, and over to Dr. Zaman. Thank you.
Thank you very much for joining in this weekend. For you, it's weekend. For us here, it's the working day. It's a weekday. So we would love to see you once again for a very special issue. This is being highly talked among the professionals. Why so many doctors, frontliners, doctors, nurses, and technicians are dying? What could be done better? And what was the missing link related to a large number of deaths among doctors? So if you and your team can support us having another Zoom meeting, would be wonderful. And I think we will be able to save lives of our senior people, because those who died are mostly senior people and mid-level people, that's a huge loss for the health system. So we seek your support to organize more meetings like this. And I'm very impressed with the comments and appreciation given in the chat box by the participants. And we have recorded this, and we will try to make a shorter version for posting into YouTube and Facebook so that it is available for other doctors who could not participate. Thank you so much.
Thank you, Mostafa Bhai. It will be our great pleasure to help in organizing other future events, especially the infection prevention and control. Thank you to all of you. Professor Landre, it will be nice to have some closing remarks from you. It's been an absolute pleasure having you here. Thank you.
Well, I'd just like to say thank you to all of you. I've enjoyed the discussion, and I've learned a lot. I think it's really important that, you know, my job is to run these trials and get some evidence, but that evidence doesn't change into practice unless it's then translated, and unless the questions we ask are informed by the sort of questions that you have on the ground. So I've learned an enormous amount, and I'd like to thank you for that. Have a good day.
Thank you. Have a good day. We close our meeting. Thank you. Bye-bye.
Thank you all. Bye-bye. Take care.
Bye-bye.
Bye. Thank you.
Thank you. Bye.